Manjula ji, are we live?
Yes, doctor. We are live now, doctor.
Very good evening to one and all of you for our I Foundation and YOSI initiative. The CataTeach Video Competition, the second version is here for you. We'll be together with all of you for the next couple of hours, and we promise you that it's going to be as gripping and as interesting and informative too. We are truly lucky to have on our expert panel Dr. Ramurthy, who's the past president of All India Ophthalmic Society and the chairman and senior consultant cataract and refractive surgery for the Eye Foundation group of hospitals. We are also lucky to have with us Dr. Shreyas Ramurthy, who's the medical director and the managing director and senior consultant, cornea, cataract, and refractive services from the Eye Foundation group of hospitals. We are lucky to have with us our young Dr. Sandeep Chaudhary, who's a consultant cornea, refractive, and glaucoma services at the Dr. Agarwal Eye Hospital, Jaipur, and a very active YOSI member. We are very happy to have with us Dr. Anujit Paul, who's a young consultant cataract and vitreoretina surgeon with great promises from the BBI Foundation, Kolkata, and a very active YOSI member. We are, as the last session, we would be having 14 participants, and the judges are going to judge them, and questions and discussions. And on the judges panel, we have Dr. Rakshit Nathan, who's a consultant cornea, cataract, and refractive services from the Eye Foundation group of hospital. We have Dr. Ayman Ahmed Khan, who's a senior consultant cataract and glaucoma services from the Eye Foundation group of hospitals, Coimbatore. We are very lucky to have with us Dr. Soumya Ganesh Nanaya, who's a young cataract and refractive surgeon and a founder and director of the Lopamudra Drishti Eye Hospital, Karnataka. Very warm welcome to all of you. And Dr. Anu Malik was an associate professor at the RP Center, New Delhi. Again, a very dynamic young leader of ophthalmology and in YOSI. Moderating along with me are three other dynamic people. Dr. Tamil Arsi, who's a senior consultant cataract and in IOL services of the Eye Foundation group of hospitals, also a FACO trainer for FACO Shala. And we have Dr. Lipi Mittal, who's a young consultant cataract and refractive surgery from the Center for Sight group of hospitals based at Palwal. And she's also the executive member of the Young Ophthalmic Society of India. We are lucky to have with us co-moderating Dr. Sonal Kalia, who's the associate professor at the Department of Ophthalmology, SMS Medical College, Jaipur, who's also the eminent immediate past president of YOSI, immediate past executive member of Jaipur Ophthalmic Society and Rajasthan Ophthalmic Society. So without wasting time, let us go on to our first speaker, and it's Dr. Rohit Rao, who's a senior consultant at Sri Ganesh Vinayak Eye Hospital, Raipur. So Dr. Rohit, could you start your video? And I would be taking the questions for this with Dr. Ramurthy and Soumya Ganesh. Yes, on to you, Dr. Rohit.
Audio, okay. Good evening, ma'am. Thank you for the opportunity. I'll be starting my video.
Yeah.
Hello everyone. In this video, we will discuss how to manage a full thickness scleral incision in SICS. Some or another day, every one of us would have faced full thickness scleral incision as complication. Here you can see incision is very deep and uveal tissue is exposed. This may lead to iris prolapse, very difficult surgery, and inability to close the wound. In such situations, our basic response is to call for help. But as you know, डर के आगे जीत है. So take few deep breaths. Now we have four options. First one is to close and abandon the case. Second, close the primary incision and convert it into phaco. Third, close and move on to the temporal incision. Make a new tunnel in a superficial plane. So, this is the first case. Here, you can see a very deep incision has been made but actual ideal incision should be partial thickness scleral incision. Normally, we go to the depth of the incision to make the tunnel, but in this scenario, it will be detrimental. So we need to go to a superficial plane to construct the tunnel, where you can see that a crescent blade moving in a superficial plane instead of going into the depth of the incision. Normally, we start at the center of the incision, but here you can see the tunnel is being started from the left side, where the incision was normal depth. Then, in the keratome entry, we have to be very careful and enter at the exact tunnel in the current plane. The tunnel needs to be featured at the end of the surgery to form the anterior chamber and prevent the wound leak. Now let's proceed further to our next case. Here you can see that the surgeon is unable to make the tunnel due to the bent nature of the incision. So now the side port is being made. Tryptan blue staining is done and then visco is injected, and another trial is done to make a superficial tunnel, but it is unsuccessful. We can see here in the video the visco is leaking. So now first rhexis is completed. Now the main tunnel is closed with sutures. Surgery site is shifted temporarily. Starting from conjunctival peritomy, a new tunnel is constructed and a keratome entry is made. Nucleus is prolapse out and the delivery is done by a sandwich technique. Cortex is aspirated and IOL is placed in the bag. The wound is then hydrated. Conjunctival closure is done. The take-home message is, if you ever encounter a deep scleral incision, you can try for superficial tunnel or convert the case into a temporal section after closing the main port. Or we can convert it into a clear corneal phacoemulsification. Lastly, but most importantly, do not disturb the iris. Thank you.
Thank you.
Yeah, that was a nice presentation, Dr. Rohit. Soumya, I wanted to ask you, to tell us what would be the safest way to teach tunnel depth assessment for a trainee, and what would be those important visual clues you want them to know?
I think it's been long since I've done SICS actually. I mostly do phaco now, but I think to have a little experience with judging, one, the feel of the sclera, and the secondly, to be able to visualize the blade enough to know that you're able to visualize it. It shouldn't be too clear, in which case you're too superficial, and it shouldn't be too opaque, wherein you're not able to see the instrument at all, and then you know you've gone too deep. So I think initially, while even starting, and probably beginners can also use a guarded knife. If judging the depth is tough, probably that can be done. But really, I think somebody that does SICS regularly and is teaching may want to add on some things as well.
Kamal, would you want to add, because you're doing was largely training of phacos, but still very salient points which should be discussed?
Yes, ma'am. I think the tunnel construction is the single most important step which leads to the success of small incision cataract surgery. And I think that is the one step which could be practiced in wet lab. So I would encourage every SICS resident to practice on both sides so that they know about the architecture of the tunnel, assess how a roof of a tunnel will feel. Second, creating a groove. I think most of the beginner surgeon would create a groove superficial, and they'll be hesitant to create a groove. So in the process, they're thinking that they are superficial. They used to undermine the groove 2 to 3 times before starting to tunnel. So never undermine many a times, which can lead to a deeper groove. And like Dr. Soumya said, the feel of the roof, the visibility of the crescent should be seen. The crescent should be just seen. If it is too superficial, or if the roof is bunching up, it means it is superficial. And if the crescent is not seen, it means it is deep. So this is a premature entry or a buttonhole is an avoidable complication, and paying attention to all these steps can make a surgeon to do a good sclerocorneal tunnel.
Dr. Ramurthy, would you have any thoughts to summarize this video before we move on to the next?
Nice, challenging video. And my thought is, as far as the points to avoid this is concerned, I think both Dr. Soumya and Tamari have highlighted the points. But I would say that if at all you are faced with this complication, it could be quite messy if iris starts prolapsing, and already I assume it's an inexperienced surgeon who is doing this. So it's always a better idea to tightly close up, as it was done in the second eye. Suture up the scleral incision and shift temporarily and complete the case. If one of the situations, if it's a very hard cataract and the surgeon is not confident, call for help and maybe let a senior surgeon take over and do a phaco emulsification or do a temporal incision for a SACS. I think going through the same incision could be a little risky. And I also saw that from the limbus, the distance was almost 1.5 millimeters away where the initial incision was made. But all you are faced with this situation, instead of going through the lip of the same deep incision where you may or may not get the right, whether you can go a little more anteriorly and then create a fresh tunnel would be something I would consider. But my first choice would be to suture up the deep tunnel and deep incision and then shift to a different site.
Yeah. I
Thank you,
think,
sir.
does anybody want to add anything on this? Any point before we go on
I
to?
like
Like,
just
ma'am,
wanted to ask Dr. Rohit if it was taken over by somebody, because suddenly the doctor seemed to have very good skills to be able to go
Yeah,
through
it
that
was
same.
taken over by me. Actually,
Yeah.
my resident was operating.
Okay.
So I took over because the uvea was exposed in both the scenarios.
Noted. I think Dr. Anu wanted to say something.
I just wanted to add some technical details of
Yeah, sure.
this tunnel making. Like the location, depth, length, as well as the plane, all four things matter. The plane should be a uniform lamellar dissection that should be parallel to the scleral surface. And the length also matters. It should be 6 to 7 millimeter external incision with a 1.5 to 2 millimeter sclerocorneal tunnel. And the location should be 1.5 to 2 millimeter posterior to the limbus. Like all these parameters matter for a apt and a self-sealing scleral tunnel.
Yeah. So thank you very much, Dr. Rohit. We shall
you,
go
ma'am.
on to the speaker and I invite Dr. Sonal to take care of the.
Ma'am, Dr. Megha is not ready yet. We can, ma'am, can introduce Dr. Anurag.
Get comment on to you.
The next presenter is Dr. Anurag Kaishyap. He is a consultant from ASG Eye Hospital, Varanasi. On to you, Dr. Anurag.
Yeah, thank you, ma'am, for your kind introduction. Am I audible?
Yes.
I'll share my screen. Yeah. Welcome to this surgical video of immature cataract where preoperative evaluation showed no obvious sign of zonular instability. However, a generalized zonular weakness becomes apparent intraoperatively with difficult capsular access. When the surgeon notices the subtle radial wrinkles over anterior lens capsule, key intraoperative clue indicating generalized zonular weakness. Even after a cautious hydrodissection, a difficult nucleus rotation warrants an early use of CTR to stabilize the bag to prevent further zonular stress. Notice the use of two dialers for correct positioning of CTR in the bag. Moving to phacoemulsification, we use low power and low vacuum settings to minimize stress on already weakened zonules. The use of capsular tension ring into the fornix of capsular bag helps distribute the forces evenly across the equator. As we can appreciate, difficult nucleus rotation along with apparent capsular bag movement, a repeat and multi-quadrant hydrodissection becomes key step to ensure complete nucleus movement. Once a satisfactory nucleus movement is achieved, The nucleus is chopped and emulsified quadrant by quadrant subsequently. Notice how the lens material is aspirated and emulsified carefully to avoid capsular trauma. Notice the importance of low phaco energy and adequate flow rates to support the capsular bag and maintain a proper chamber depth throughout the emulsification. Avoid any sudden capsular trauma. After the complete cortical wash, we now implant the single piece intraocular lens into the capsular bag. The incisions are hydrated and sealed, ensuring a watertight closure.
Thank you, Dr. Anurag. That was a very meticulously done surgery. Since the next video is also on a subluxated cataract, I would like Dr. Lippy to introduce the next speaker, and we would like to have the discussion for both cases.
So our next speaker is Dr. Anup Kumar Singh. He's a consultant at ASG Hospital Varanasi, and his video will showcase a cataract surgery in a traumatic subluxated cataract. Dr. Anup, I'll share the video on his behalf. He's there. Is it audible?
Here, presenting an unusual case of traumatic subluxation with around 270 degree of zonular dialysis and merely 4 to 5 zonules holding up the lens from posterior dislocation. Rhexis is one of a key step in the success of the surgery. Capsular rhexis is performed preferably with forceps for better control and is initiated away from the dialysis and aimed at a large 5.5 to 6 millimeter opening for easy nucleus manipulation. Again, CTR is implanted in the bag in the initial step itself to stretch the capsule and make the further procedures easy. The choice of technique for zonular support depends on the extent of zonular loss, where a standard CTR can be used in case of 3 to 4 clock hour of zonular dialysis, while modified CTR like Chioni's ring or Amos segment can be used in case where the zonular dialysis is more than 3 to 6 clock hour. Use of iris and capsular hooks can also be considered. Multiple level hydrodissection and delineation is attempted to separate multiple layers of the nucleus and epinuclear plates. Machine settings are ideally kept low to prevent the surge and the fluctuations in the anterior chamber in order to protect the zonules and the other surrounding structures. During cataract removal, low and gentle phaco settings are recommended and manual aspiration if needed is considered for softer cataracts. Multiple repeated hydrodissections can be done, and the central portion of the nucleus can be taken up into the anterior chamber for further heat up and emulsification. Cortical aspiration is done gently through all the quadrants and slowly and carefully, preventing the anterior capsular rhexis aspiration and holding it into the probe. Indirect method of loosening the cortex stuck behind or around the CTR can be done to ease the removal. Then the sandblasted tip of the aspiration cannula can be used to scrub off the loose cortex in the bag and around the pin. Intraocular lens implantation is preferred in the bag if sufficient zonular support is present. The direction of the IOL insertion should be towards the healthy zonules because the push of the bag at that area will be easier and the manipulation will also be easier. IOL is gently placed in the bag and dialed along the areas of weak zonular dehiscence in order to push the bag peripherally and prevent any vitreous prolapse from that area. A tight anterior chamber is ensured in order to achieve the good centration of the IOL and a well-formed anterior chamber without endothelial or vitreous related complications. Post-operative care and management include close monitoring for elevated intraocular pressure, inflammation, infection, and associated retinal complications. Successful surgical management of a traumatic subluxated cataractus lens require a flexible approach, meticulous technique, and preparedness for a range of intraoperative challenges. But a gently done surgery is always rewarding.
That was a very beautiful video, Dr. Anu. My question is to Dr. Shreyas. Both of them have used CTR as an support device in their cases, though the first one was a generalized zonular weakness, where the second was a traumatic cataract. Would your approach would be different, Shreyas? Would have you used capsular hooks first and CTR later, or?
100%, madam. I mean, that would be my go-to technique. I mean, I think I first should congratulate Anurag and the other surgeon. Sorry, I didn't get his name. For excellent surgical videos. Both of them are very good. The advantage of using a capsule hook first is essentially that one, you're able to hook the anterior capsular leaflets forwards, which one apart from providing stability right up to the equator, it also helps for easier rotation. Like we saw in Anurag's video, despite a very nice CTR insertion, the subsequent rotation of the nucleus is always challenging. And especially if it's a case with, let's say, like a PXF or other things where the rest of the zonules also tend to be weaker, that very action of rotation, the forceful action of rotation can cause further weakness in the zonules. So having the capsule hooks will definitely help in preventing it. Having said that, I would definitely use a CTR, but maybe as I do after the chops and as I evacuate, a couple of pieces, that is when when the bag becomes more and more empty, you will notice that then the posterior capsule also starts billowing a little bit. That is a good time to again refill with viscoelastic and put in a CTR. Now you have more space in the bag to insert the CTR. CTR insertion becomes easier and less traumatic to the bag itself. The very action of CTR placement itself would be less traumatic. If at all I have to place a CTR first, like in I think Anujit's case, again very nicely done, Phaco, I would create some space between the periphery, and there the equator was also visible, going in with a cohesive viscoelastic, heavy molecular weight viscoelastic, and creating a little bit of space, and then threading the CTR into that space. Of course, I'm sure you'll discuss about CONE as well in the subsequent questions, but maybe a CONE in addition also would have helped in that particular instance.
How do you plan the number of capsular hooks to be used? In the second case, there was like around more than 6 clock hours of zonular weakness. Would you plan only at that site or 360-degree Shreyas?
In a traumatic case, I wouldn't mind using just 3 capsule hooks in that 6 clock hours. That should be sufficient to hold it in place because the rest of the zonules is normally good. But if it was a diffuse weakness like pseudoexfoliation, then I would have it more equally distributed 4 capsule hooks, which is spread across the 4 different quadrants. But in this particular case, even 2 or 3, and usually I would have preferred 3 in a little more close proximity so that you have a better hold in that region to keep the capsule lifted and preventing any. And also, one additional good thing which it does is usually during your phaco, it enables that the bag stays up. So any fluid misdirection, fluid flowing into the vitreous, prolapse of anterior vitreous, all of this can be avoided because the plane of the capsular bag remains horizontal at all times when the capsule hooks are used.
My next question is to Dr. Would you like to differentiate the cause etiology of the zonular weakness, like progressive, non-progressive, and your choice of capsular support device would vary depending on that?
Yes, ma'am. So especially traumatic cataract. So I think he was sitting.
Anu.
Oh, sorry. I got confused.
Yes, Anu.
Yeah, for progressive zonulopathies like PECs or Marfan's, or we would prefer CTR more, like and capsular hooks and this capsular tension segments. They are ideal for localized zonular loss. Like unlike CTR, CTS, they do not exert the circumferential stress and they allow the selective reinforcement. So they further minimize the zonular damage also. So definitely, the choice depends upon the progressive zonulopathy or zonular weakness. And in cases of traumatic subluxation or pediatric cases, we can prefer implanting hooks and then the CTRs.
Dr. Anujit, you were commenting? Can you?
Yes, ma'am. So he's sitting temporarily. So this is an inferior subluxation. I feel that this lens will just keep falling as the years go by, in spite of it just being a traumatic one. So definitely fixate the bag is something that I would focus on. And something that is not shown in most teaching videos or in videos that we see is that initiation of the rhexis, it usually doesn't happen the way that it is shown on stage. There are many times where it tends to run out. So the only addition that I would say is that as soon as you initiate the rhexis, put the first capsule hook, extend the rhexis, put the second capsule hook, especially even if it's 4 clock hours, I wouldn't mind putting 3 capsule hooks in that region just to stabilize the bag, and then try to bring the bag as center as possible. That would help me in my future steps, because getting around rhexis is the most crucial thing in such a case. That actually saves most of the surgery, which is usually not shown in most teaching videos. I felt that that could be just added over here. That point could be stressed on, that when you're attempting your first or your second or your third, that's the most difficult step, getting your rhexis right.
Very vital. Lipi, you want to take some?
Yes, I would like to ask Dr. Ayman Ahmed, sir. Sir, what are your tips you would like to give to a young ophthalmologist while planning a case with subluxation?
Yeah, I think very beautifully described in the video, but now I think again regarding the rhexis, we always talk about getting the rhexis centered onto the nucleus itself, onto the lens itself. But I think what Dr. Anujit said about getting it centered early really helps in getting it, getting around rhexis. One thing is we try to make it slightly on the smaller side, like you might be afraid that it might run off. If it becomes small and if it's a denser nucleus and already there's a subluxation, then it becomes a little more complicated. So obviously try to make a well-centered, but don't make it too small. Don't make it 4, at least 5 to 5.5 would be needed, especially if the if the nucleus is dense. Again, in this case, I don't think staining was needed, but if you have to stain, avoid injecting it into the whole of the anterior chamber. I would suggest you paint it on, like after injecting viscoelastic, put a couple of drops on top of the lens and just paint it on. So you can get a good visualization and you can complete the rhexis well. And this particular video, I really liked the use of multiple hydrodissections just to separate out the different layers. It actually really helps to just take care of the nucleus much more efficiently. So those are the few points I just wanted to add.
No, but I also felt before placement of the CTR, I would like to do a hydro and get my nucleus rotated before I place my CTR. But Anup has placed the CTR and then gone in and done a hydro. Anybody feel?
Couple of points I just wanted to add. This is a very nice discussion and excellent videos also. One thing is, especially in the second case where there's an obvious subluxation and you can see an open vitreous space, it's always a good idea to start with putting a blob of dispersive viscoelastic where there's a subluxation, so that that sort of tamponades the anterior vitreous space. And then obviously you cannot put in an endocapsular ring without doing a hydrodissection, because you have to create space. It must have been done. But I feel especially in the first case, though things went well, the rotation was a little excessive, as was pointed out. Rotation of the nucleus without capsular support, with the capsular hooks itself can compromise whatever little zonular support that is there, and can make the surgery a little more tenuous. Other thing, as far as the choice of intraocular lens is concerned, this is one of the situations where the three-piece lens might be preferred compared to a single-piece lens, because the haptics of the three-piece lens acts as further support for the capsular bag. Even better way, as described by David Chang, is to place the lens, especially in the first case, where the subluxation is not too obvious and the bag is reasonably well centered. You can place the lens in the sulcus and create an optic capture. This itself stabilizes the bag quite well. And as was discussed, I think, especially though it was a traumatic cataract, more than a CTR, I've shifted over to using a CTS now. That's more controllable, easier to maneuver. You put a CTR, complete your surgery. The CTS is put more to fixate the bag for the lifetime of the patient, because zonulopathy, if it's progressive, like in pseudo exfoliations,
Patient
marfan,
depth,
uveitis, etc.
7 millimeter external incision with a
What
1
is happening,
to
Deborah?
2 sclerocorneal tunnel, and the location should be 1.5 to 2
What is
millimeter.
happening? Can you mute, please? Yeah.
Yeah, so use of a CTS would be a good idea. And one last thing I want to comment is, I don't know whether you noticed in the last second video, the endocapsular ring had a gap in between, and that the area was overlapping onto the area of the zonular dialysis. So I like to make sure that I get a complete ring. So when you order for the endocapsular ring, make sure that it's almost the two eyelets are touching each other and there's not a large gap. In case you have an endocapsular ring like that, then make sure that the PMMA of the ring comes in the area of the where the zonular dialysis is there. Otherwise, that ring may not be offering enough support. I could actually see the eyelet of the ring in the area of the dialysis. So maybe rotating it in such a way that there's enough of PMMA support there would be a good idea.
Yes.
Sorry, ma'am, I would like to just mention few points related to the second video. As had already been discussed, while operating, I have put the compression using the viscoelastic in the areas where there is a zonulopathy. And moreover than that, I don't know whether it was very much clear in the video or not. There, along with the 270 degree of the zonular dialysis, there was a bunch of capsules, zonules were there. And my point of the video was there that those zonules were so strong enough that in spite of manipulating it and dialing up the lens and the nucleus, those zonules held till the last. So the requirement of the CTS, I had kept it in backup, but I didn't feel by the end of the surgery, centration was good. And those zonules, almost all of the zonules remained intact till the end of the surgery. So after analyzing the situation throughout the course of the surgery and as per the manipulation, I have decided accordingly the maneuvers. And whatever sir is mentioning, the point is noted that both the eyelets were wide apart. But since the degree of zonular adhesions was that much strong, so just the size of the bag when it is stretching up after the implantation of the CTR will be a little bit larger than the normal one. So
because it's a traumatic case, it
yes,
is to progress further. But there is a possibility you have to keep reviewing this person.
yes,
If there
ma'am.
is a possibility that it could get decentered, and you should not wait for it to sink into the vitreous.
Exactly. So in spite of the size of the three-piece lens being large, I counseled the patient to choose and go for the three-piece lens because it will be further advantageous for us for the stability of the lens.
Yeah.
No, point well taken, Dr. Anup. But the only challenge is that while things look centered on table, when you have such a large, almost 6 clock hour zonular dialysis, it's a very asymmetric force holding the bag. So, throughout the lifetime of the patient, the saccadic eye movements and other things, there's always a greater pull on one direction with absolutely no hold on the, or very minimal half a clock hour hold on the other side, which is what, is behind the hypothesis behind progressive zonulopathy in many of the situations, not just PXF, in many situations. And that's why when we have a larger dialysis, we tend to use a CTS and anchor the bag. But yes, you're right. Very often on table, IO looks centered. We often feel that nothing really is required. Whether it's something will be needed 5 to 10 years later is really the question.
Thank you very much. We shall go on after a very good discussion. Go on to our next speaker, Dr. Aniksha, who's doing a fellowship in general ophthalmology and cornea and Arvind Eye Care System based at Pondicherry. So on to you, Aniksha. And a discussion in this is going to be with Dr. Shreyash Ramamurthy and Dr. Rakshit.
Thank you, ma'am. I'll share my screen. I hope my screen.
Oh, sorry. This is Megha.
You are muted.
Dr. Anish, mute.
What has happened?
Aniksha, unmute.
Why is sudden echo happening?
Aniksha, you have lost network?
Now can you hear me, ma'am?
Yes.
And your video.
I'll just share my screen.
Aniksha,
Dr. Aniksha, you're muted.
what is happening?
Aniksha, unmute yourself.
It's not happening?
No, I think she's running the live in the background, ma'am.
Oh. So what do you advise? I think Aniksha, Velmurugan, I think talk to her and get this sorted out. In the interim, Sonal can go on to Dr. Megha's presentation. Yes,
Okay.
Dr.
Okay, so I would now request Dr. Megha if she's present. Are you present, Dr. Megha?
Yes, Dr. Sonal, I'm right here.
Yeah, so a very, very important topic, very close to the heart of a lot of young ophthalmologists, to be more green. And let's see how Dr. Megha is going to share that with us, that how to make the cataract surgery more sustainable. Over to you.
Yeah. Thank you so much for the opportunity. Yeah, as Madam just introduced, most of us are thinking cataract in terms of how we can be better surgeons, but I also feel we need to see how we can be better humans while performing the cataract surgery and how we can be better to Mother Earth while doing so. So I'm just sharing a small 1-minute reel regarding the same. I'm just sharing my screen.
I think the audio is muted or something. We are not able to get the audio.
The audio is not heard?
No.
No, I think maybe the
Okay.
audio on the surgical video is muted or something.
Yes, please share it again.
Cataract is the most common
What
surgery.
about now?
One phaco in the
What
UK
is-
generates same carbon emissions as driving a car for 500 kilometers. At Arvind Eye Care System, it's equivalent to 25 kilometers. How? Reduce single-use disposable. Use reusable eye drapes, reusable caps, footwear, and gowns. Patients walk in their own dresses. Reusing gowns and gloves for cases by using hand rub. Reusing surgical supplies like instruments, cannulas, syringes, brittle sutures. They are washed and flash autoclaved in between cases. Reusing IV tubings as caps. Multidose pre and post-op medications, irrigating solutions. Reusable cartridges. Reusing vitrectomy and phaco probes and cassettes, emptying drainage bags. Thorough waste segregation, sending for recycling. 5 R's: reduce, reuse, recycle, repair, and rethink. Cataract.
Excellent presentation, Dr. Megha. Before I move on to the judges, who would be the discussants for this would be Dr. Sandeep and Dr. Rakshit. Before moving on to them, just want to ask you, in your own experience at Arvind Eye Care System and elsewhere, from what you've learned till now, what are the most important challenges that you see for these sustainable practices to be adopted on a large scale?
Difficulties, since we're already practicing it, and we have proven time and again that infection is not a thing. The most important thing which we are scared of, and why we are using disposables, are because we are scared of endophthalmitis. But we have proven with multiple studies across millions of patients that the rate of endophthalmitis in ours compared to UK is at par or even lesser in compared to many of the countries. So I think by adopting many of these, it's really possible for any large-scale institute also to follow this. Maybe not full-fledged, but at least to a certain extent, say 30-40% of whatever we have suggested.
Okay, Dr. Sandeep and Dr. Rakshit, if you would.
Thank you for the question, ma'am. So I think, nice video, nice short video by Dr. Megha. So I think with respect to sustainability, whatever she said was absolutely true in terms of infection, which is the biggest fear when you try and reuse these instruments, which are supposed to be, many of them are marked as single use, at least disposable syringes, cannulas, etc. I think apart from endophthalmitis, which now we have seen with the current practice and of course the low rates of endophthalmitis, the other thing is inflammatory events. I don't think these are studied as much as endophthalmitis, or not as reported as widely. So whether something like TAS, delayed TAS, or persistent inflammation post-op because of this reuse is something that really hasn't been looked into. But otherwise, I think in general, to answer your question in terms of the difficulty, I think India as such, I think most people, most practitioners do end up using a lot of these instruments with apparently no negative consequences. But I think something that should probably be looked into is standardization into how many times it can actually be used. When is the last time you can sterilize? Is it till it breaks? So I think in order for it to be more standardized and to prevent the fear sort of thinking coming into reusability of instruments, is to have a limit. Even if you have a microwavable BPA container, even that has how many times you can actually microwave it. In a similar sense, I think the studies should focus on how many times can these instruments actually be reused safely without a change in the chemical inertness or the property to leach out any of these chemicals in the long run.
Yeah, makes great sense. And that quality, that physiochemical properties which could be hampered, which has to be looked into for this to be adopted with greater confidence on a larger scale. And there has to be some guidelines for its usage, which will make it more make greater sense for a population at large. So very true. Yes, on to you, Sonia.
Yeah, so as far as I believe the metallic instruments are concerned, like the cannulas and all, I think how many times it can be autoclaved should not be an issue because we are using the other metallic instruments like the needle holder and all are also autoclaved. Just a few things like some things like a cannula which is used in visco needs to be washed thoroughly, otherwise it gets dried on and sometimes gets stuck into the patient's eye while we are injecting when we are not we don't know if it is blocked or not. So apart from those things, I think metallic instruments can be autoclaved as long as they work. And just one concern I have is that I believe surgical gloves and sutures are classified under single-use devices. So maybe we can avoid using gloves, as you mentioned. So apart from that, I think it is the sustainability, knowing that it can reduce the carbon emission by 95% is really amazing. Yeah.
Yeah.
Ma'am,
So,
are you using these practices at your chain of hospitals?
no. Maybe we use phaco tips. That also we change phaco tips and tubings, and that too we would not carry it to the next day. We would be using that phaco cassette or the tubing only on that particular day, and we would not do that. And the blades, of course, we would do ETO for them and all that, like that kind of thing. But again, things can get blunt. There has to be a limit on the number of usage, you know. So that has to be something kept in our mind, and it should not be overused. And that is a message which has to be kept in mind. And Rakshit very relevantly said that for that small amount of inflammation which could come up in these eyes. So if it is used continuously, and not to mention some residues in these things, and it doesn't make sense to use a detergent to clean it because that could itself trigger of a task. So all that you're doing is just cleaning it with full force of water or the sterile water. So you have to keep in mind that we can't, how much can you reuse it? These are thoughts, these questioning thoughts should come in our mind so that then we come to a more complete decision taking.
Oh, to answer your question, Dr. Sonal, I mean, we definitely reuse instruments, but not without autoclaving them, in the sense that between from one case to another, whether it's drapes or instruments or tips, everything is autoclaved and reused, including blades, and I think still system as they're usable. But the proof of the pudding is in eating. My Arvind Eye Care system is shown in millions of cases with multiple very well documented publications that has worked well in their hands. So we have to accept proof. But as was pointed out by Dr. Sandeep, I feel that using gloves again without changing for the next case may be a little unacceptable to me. We definitely discard gloves after each case and then put on fresh gloves. And I think another important aspect is for the safety of patients from one to another. If at all you are considering using this, then HIV, HPSAG testing should be done mandatorily in all these patients, because if there's any tears or anything that's being carried forward to the next patient and the one is contaminated, you might be inadvertently transferring this.
Right. So are you routinely testing, Dr. Megha, for HIV and HPS? Very valid point, sir has pointed out.
No, madam, not for all the cases. If they are known patients, we just do it, but not for all the patients. We don't check HIV, HPSAG. But as sir pointed, we are reusing only after autoclaving or doing some kind of sterilization based on whatever the instrument or whatever this thing is. So we are not reusing without, not just reusing for the next patient.
That's what I also noticed. That's the
Yes,
reason I
yes.
specifically emphasized about gloves. Of course, you are using some sterilium to clean your hands,
Yes,
but
yes,
then
sir.
I think that's not good enough. Maybe that's one aspect I might not agree, but I mean, all the other things seem to work in your hands.
As an institutional practice, SMS does HIV and HPSAG for all the patients before they are taken into surgery. I think that's very important because then we separate the table for those who are having positive viral markers for those particular cases. The table and the instruments are separated that day.
Yes.
Also, I would like to know sir's opinion, ma'am's opinion about like a very simple thing that the patient walks in their own dress. So should like in our hospital we put on a gown on top of that, whatever they are wearing, and in my institution where I did my MS, so at that they used to get like the patient had to change the whole clothes and then come in the OT dress only. So does it make a difference? Like, what's your take on that?
So we do believe that patients do have to change their dress and definitely cover their feet also. So these are important things which we follow. But we have a very healthy respect for the Arvind eye care systems too. So I'm sure when it comes to huge volumes, probably these small compromises which they're doing, they feel that does not affect the patient safety at large. So
Yes, sir. We give them reusable or disposable the footwear and the caps, but the dresses they walk in their own dresses. We don't, but they remove their own sandals and put that shoe cap which we have.
Yeah. Thank you, Megha.
Thank you so much, madam.
Moving on to Dr. Mohammad Afzal from Army Medical Center in New Delhi. He'll be sharing about the complex capsulorhexis in cases with corneal opacity. Are you there, Dr. Mohammad Afzal?
Aniksha apparently is ready.
Am I audible now?
Okay.
Yeah, you're audible. I think your video will be played by Yes.
Actually, I am in a low network area. That is why I am unable to play my video.
Yeah, okay. So please, somebody else can play that video. Is there an audio with this?
No, ma'am. Dr. Mohammad Afzal.
Am I audible now?
Oh, you're not audible. Now you're audible, yeah. You can start talking.
This is a cataract surgery being performed in a patient having a corneal opacity, and the patient was having a cataract. Along the procedure performed was PK along with phacoemulsification and IOL implantation was done. So initial trephination for PK was done, and this is a skyrocketing technique for continuous curvilinear capsulorhexis. This is the pupil expander because of the lesser visibility. Corneal opacity was limiting the visualization. Now the IOL has been implanted. And now sutures penetrating keratoplasty will be performed. This open sky rocket technique reduces endothelial loss at the graft edge, and it eliminates tunnel-related size limitations. Post-operatively, the patient had good visual prognosis, and the vision was 6/60 after a week. Thank you so much.
Yeah, can you stop sharing? Dr. Sonal, can you unmute yourself? Sonal, can you unmute? We can't hear you, Dr. Sonal.
Yes, ma'am. Yes, ma'am. I'm trying to say this. So, ma'am, I have seen the video and just wanted to know if this particular technique that you've used here, is this you're sharing this single case per se, or you have been practicing it in a lot of open sky kind of in a lot of cases, or like what has been your experience in these cases? Not just this case, like in general.
Ma'am, we are doing this in our tertiary center in our patients whose visualization is very difficult in patients having severe corneal opacity. And these are rarely being performed, means the incidence rate of doing this surgery is quite low.
Yeah, that is, I'm just trying to ask about
Yeah,
your own
yeah.
personal experience in these, like, if Ramamurthy sir can weigh in with his.
Oh, I'm not a cornea surgeon, but the surgery looked very impressive, and the way it was tissue handling, and especially the iris expanding device, that was pupil expanding device that was used. I'm familiar with that, but it's quite bulky. Something like a BX ring with a thinner profile might have been easier to handle. One thing which always bothers me with this, though the surgery went off very well with this open sky, is that the entire eyeball remaining open for so long, and whether sudden vitreous upthrust and chance of expulsive other things are there. But otherwise, I don't have much else to say.
Dr. John, next, Aniksha.
No, any of the cornea surgeons like
Sorry, I was just testing.
Rakshit or somebody who can comment on this?
No, fantastic video. I mean, I was just thinking, what has he done so differently that he's keeping everything so calm and quiet? I mean, it's not an easy job to put any kind of pupil expansion device in open sky. Usually there is sufficient amount of upthrust, and to be able to do that rexis so neatly, so calmly, very, very beautifully done surgery. Oftentimes, the pupil tends to expand on its own because with such a intumescent cataract lying inside, a little bit of minimal stretch pupilloplasty itself will cause the pupil to expand significantly enough. And you can take out, do a, even through a slightly smaller can opener, you'll be able to remove the entirety of the nucleus. But otherwise, beautifully done surgery, and kudos to him for managing it in such a nice, quiet, calm manner.
What I would like to know is, what are the chances of vitreous loss, expulsive hemorrhage in these cases when in open sky the eyeball is remaining open like this for so long?
I mean, it's not necessarily, obviously, when we will be able to see upthrust happening, the PC billowing up quickly. I think if adequately, mannitol has been put in, and a block, and subsequently we go do adequate massage. Suprachoroidals and expulsives are not very common. It's still an exceedingly rare scenario, even in an open sky PK triple procedure like he showed. But having said that, the amount of time that he had to do some of the steps, yes, may not be possible. At times, even the IOL becomes insertion becomes a little difficult in some of these situations where the IOLT keeps tending to pop out. So very nicely, he ensured that it was taken back. The trailing haptic was pushed behind the iris before it can come out again. Sometimes we even have to, when the upthrust is high, start the PK, put in 4 to 8 sutures, then put in viscoelastic, complete the cortex wash, and put in the IOL when the situation is a little more stable. Those modifications will be required from time to time when there is an upthrust.
Yeah, I think I'm going to go to the next speaker, and we'll have to do our discussions a little faster, so Dr. Sonal, because we've just done 4 videos this far. Would you be presenting your video, Dr. Aniksha?
Yes, ma'am. No, ma'am, they will share my video.
Okay, Vel Murugan?
Yes, ma'am. Ready, ma'am.
Sorry for the glitch. Good evening, one and all present here. My video for today is wet lab using smartphone. As wet lab is crucial for any postgraduate resident before operating on actual patients. Like how Tamil ma'am also emphasized on importance of wet lab practice. But only few teaching institutes are equipped with wet lab, and even those that facilitates has limited access due to outnumbering of doctors to the number of microscopes. I began my post graduation during COVID, where there were
I
no
don't think the
patients.
video is playing. Is it playing?
No surgeries. Yes, ma'am. So we started exploring innovative ideas like smartphone fundus photography, glove applanation tonometry, like fixing inflated glove to slit lamp and practicing applanation tonometry. And using tennis ball to learn fundus examination, slit lamp photography. Then what about surgeries? So this is when we came up with the alternative of using mobile phone into an accessible alternative.
Place your
for
phone on a support at a particular working distance, say 15 centimeters. Now your phone's camera acts as a microscope with flash as coaxial illumination. Your phone screen acts as eyepiece of microscope, looking through which you can practice suturing, capsulorhexis, and many more techniques. The limitation of this technique is that it lacks stereopsis.
So this is in camera mode set to video with a flash enabled and image is zoomed in. So using this technique, you can even record your own practice sessions. You can review it and share it as and when required. It also helps in comparing and monitoring your progress when you compare other videos of yours. And it also helps improve your hand-eye coordination. So for beginners, it is cost-effective, accessible, portable, user-friendly method which allows you to practice at your convenient place and time. You can even practice capsulorhexis in a boiled tomato using a stapler pin as an entry port. So thank you for the opportunity. I'm grateful to be part of this webinar, and I'm so sorry for the glitch.
Yeah, it is a nice video you have shown us, a low-cost tool for beginners. However, yes, it cannot replace the depth perception and the optical magnification of a microscope. I'm sure you've also mentioned that. But most importantly, it is, when you do it on these surgical videos, you do watch your mistakes and get it corrected with your mentor. That would be the kind of learning long term, but COVID, you were limited. Rakshit, I want your thoughts, and Shreyash, your thoughts on this presentation.
Very innovative stuff that's been shown in terms of practicing surgery. Of course, ideally you would practice with stereoscopic 3-dimensional view with an operating microscope, but the next best thing is doing something like this. I think particularly for something like suturing, where there is some component of muscle memory that is involved, just getting those movements to flow. It's not a bad idea to kind of do this. It would be better with a surgical microscope, but this is the next best thing. A nice innovative concept. For cataract surgery, I'm not sure how it would translate, especially the touch and feel of everything be very different when you actually do the surgery. But I think for suturing, at least, it seems fair.
Shreyash, any comments?
Oh, very Very nice. I mean, not much experience with any of the things which Dr. Aniksha did, so I won't be able to say whether it helps in corneal practice. But yes, as Rakshit was mentioning, very nice, and everything which you did, even in that video, Dr. Aniksha, I should really comment on how neat and how beautiful it was. Even the suturing, those 5 sutures were equidistant, equal length, very nice. So definitely, if that's how you suture your ECC tunnel, I'm sure the patient will have an excellent outcome. And I'm sure even reverse sutures, like Rakshit was mentioning, different angulations, different things, how to hold it, what would be the way you would hold it, all those things, I'm sure it helps. And the fact that you were able to use a smartphone to do most of this makes it really handy, and anybody could do it at home as well. Great.
Thank you. Thank you, sir.
Thank you, Anisha. So we go on to Dr. Lipi, your next case.
So I will introduce, till Lipi is trying to figure out her video issues. Dr. Shantanu Gulati is from Jhansi. He's going to present his practical learnings from Iris Claw IOLs.
Yeah. Good evening, everyone. I'll be sharing my video.
And we'll request Dr. Sandeep and Dr. Rakshit to please discuss after the case.
Is my video visible?
Yes.
Yes.
Hi everyone, this is Dr. Shantanu Gulati, and today I'll be presenting on pearls for managing intraocular dynamics in your first iris claw implantation. We all know the textbook principles of this procedure, be it adequate vitrectomy or well-placed side ports. This video aims to highlight how the eye behaves during the procedure and the common problems that can make one hesitate or even abandon their first attempt. When placing the iris claw IOL in the anterior chamber, the first approach is a 2-step technique, introducing the IOL at 90 degrees to the wound and then bringing it into axis with intermittent viscoinflation. The second method is a single-step entry achieved by radial wrist deviation during insertion and ulnar deviation to align the IOL. The third option is direct entry when the wound size permits. The advantage with the latter 2 techniques is a single-step insertion and enclavation, reducing IOL handling after entry, often one of the most challenging steps early on, as you shall see here. In our attempt to protect the cornea, we often overfill viscoelastic above the IOL, which pushes the lens against the iris and leaves no working space for forceps entry. Also note that the bulkier your choice of forceps, the more difficult it will be to manage the IOL inside the anterior chamber. So instead, what we should aim for is to fill the viscoelastic both above and under the IOL to create a working space on either side, and to get comfortable with a sleeker iris claw forceps with a lower profile. Next, we slide it into the anterior chamber with forceps posteriorly directed, catch the IOL and enclave. Another rate-limiting step can be enclavation in a small pupil, which can occur often after pilocarpine installation. What has worked well in my hands is entering through the main port itself with an iris repositor and using a bimanual approach to gently displace the iris, creating space for posterior positioning of the IOL, followed by enclavation through the side port with the same instrument. Apart from the choice of forceps, what matters equally is the enclavation instrument. I have found that an iris repositor is the least damaging to the iris and has the added advantage of its use in small pupils, as I've mentioned previously. Another step that catches you off guard with its exceeding difficulty is using the non-dominant hand to catch the IOL while enclaving the second haptic. A useful trick is to hold the forceps with both hands, enter the anterior chamber with a slight posterior direction, and secure a stable grip on the IOL. Once the grip is firm, release the dominant hand to take the repositor from your assistant and proceed with enclavation. Using both hands provides better stability and is far less unsettling to both the surgeon and the anterior chamber. The next challenge is achieving a round pupil post-operatively. While several tips exist to address this, what I have found most relevant is ensuring that at the time of actual enclavation, the IOL forceps complex is positioned exactly at the center from each 180-degree limbal reference point. The last point is being mentally prepared for de-enclavation in certain situations, such as a broken haptic or a dangling IOL. This requires using an iris repositor to enter behind the iris and pushing down on the iris claw clip while simultaneously pulling the optic away using a sleek IOL holding forceps, causing iris release. The same is demonstrated here in a case where the left-sided claw is to be de-enclaved in an IOL dangling from the right side. A McPherson catches hold of the visible IOL optic and the repositor, slid behind the iris, presses down on the clip to release the iris tissue. These were some of the challenges I faced during my initial cases and the adjustments I learned over time that helped me overcome them. I hope these practical points make early attempts smoother and more predictable for others. Thank you.
I think that was an excellent video, and the surgeries. I mean, congratulations. You fit in as much as you could regarding the challenges in iris claw in those 4 minutes. I think that was really fantastic. I think most of the points you've already discussed. I think how to avoid the cat's eye. I think the point of enclavation is where most of us go wrong, and this can happen from the beginner to the expert surgeon, where if you enclave too peripherally, and this can happen when you're still holding the forceps with your dominant hand and you're trying to enclave with the other instrument. If you end up too peripheral, then you're going to end up with a cat's eye. You try to be more mid-peripheral in your attempt to enclave, but otherwise nothing to add. Excellent video and excellent articulation.
Yeah, excellent video. Just one thought, like I think adding an AC maintainer would make your life easier, especially in the first few cases, is what I felt personally. And apart from that, like the position of two things which I believe in the beginning are a difficulty for a new surgeon are the position of side port. It should be like a slightly posterior limbal towards the sclera and a short intracorneal tunnel. That actually helps, and with the enclavation. And another thing, if we can mark the exit site of this the point of enclavation with reference to the iris claw forceps, that also helps, I think, in the initial few cases.
Maybe you should definitely do a PI in all the cases.
And yes,
and if it's a fragile atrophic iris, maybe you could change the clock card. It's not necessary. It has to be only 3 o'clock, 9 o'clock. You could position it, but yes, maneuvering might be a little challenging because there was an area of atrophic iris. Otherwise, you should enclavate it at one go so that you don't keep repeating it.
If you're dealing with a little softer and atrophic iris, you need to get the enclavation done at the first try. Otherwise, you end up cheese wiring that iris, and then you'll have to change clock hours, which becomes a little bit of a mess.
So should we go on to our next speaker, Dr. Taman?
Next speaker is Dr. Pranesh Ravi, a consultant cataract, cornea, and refractive surgeon from the Eye Foundation, Hosur. On to you, Dr. Pranesh.
Thank you for the introduction, ma'am. So I'll start my presentation now. Is my video visible, ma'am?
Yes.
Yes.
Okay. Hi, my name is Dr. Pranesh Ravi. For this presentation, Scaffolded Time Saves 9, I'll be talking about how I addressed doing bilateral cataract surgery for a patient with bilateral mature cataracts and how I did it safely using IOL scaffold technique. I had multiple comorbidities to address as shown here before going ahead with this case. This was my action plan while addressing this case. We are doing bilateral cataract surgery in this patient on the same day. This cataract which I'm dealing with here was a bit dense, and I had to go ahead and do a safe maneuver while addressing this cataract. So what I did was I did the microrhexis technique, where I initially started with the microrhexis and rebuilt the mature cataract. This was more like a type 3 mature cataract, where the cortex was a bit more fluffy. So I debulked it, and then I enlarged the rhexis by making a nick to an adequate size. My action plan for this cataract was to tilt the nucleus out of the bag and then scaffold it initially, even before starting the phaco, so that I can comfortably go ahead and doing the case. You can see the eye moving out of the view few times. This is because the patient was a bit uncooperative, and my assistant was adjusting the eye with accordance by looking at a video so that I'd be able to operate this patient comfortably. After completing the capsulorhexis, the nucleus was lifted out of the bag, and then I tilted it up to give space for the IOL scaffold so that I can continue with the nucleus removal. Now I insert the IOL into the bag so that I'll be safe from the positive pressure of the patient, and I can do the phacoemulsification really comfortably in this scenario with the IOL acting like a scaffold for me so that I'm staying away from the posterior capsule. There was minimal cortex, and the cortex behind the IOL came with the phacoemulsification itself. The second case also the same mini-rhexis technique was done, but the cortex was not fluffy. It was more like a type 1 mature cataract. For the rhexis, I used the cystotome, and the scaffold is done at a different place after removing a few pieces of the nucleus. I'm doing minimal hydrodissection and just rotating the nucleus to free it up to move ahead with phaco. I'm just using the skull to make a small burr into the nucleus so that I can hold the nucleus quite well so that I can chop the nucleus using the direct chop technique. And once the two chunks are removed, I make space in the bag for me to place the IOL and then use the scaffold to eat up the other two quadrants. Cortex aspiration, AC formation, and the case is done. This is my CataTeach moment for using the better use of IOL scaffold in a bilateral cataract surgery. The scaffolds are used at different scenarios of nucleotomy for safe and effective removal of the nucleus in white mature cataracts. Thank you for your patient listening.
That was a very difficult case managed, Dr. Pranesh.
Thank you, ma'am. Just one second, ma'am. I'll just stop sharing. Thank you, ma'am. Thank you very much, ma'am.
My question is to Dr. Anujit. See, I've used a scaffold technique in a hypermature cataract where we are expecting a small, dense endonucleus, but here it is an intumescent cataract where the nuclear thickness is also large. So, are there any specific concerns, or what is your take on this technique?
Ma'am, I've actually never tried this technique in case of this, because after a 4-quadrant chop, I would just think of just emulsifying the nucleus and then going for the thing. Also, I just had a question for Dr. Pranesh, is that why did he shift from superior to temporal in both cases after the rhexis was completed? So he's smiling.
Actually, I very good. Actually, basically, I would want to complete the rhexis safely. For instance, if something happens, I would want to move ahead. It's just my old way of doing things. So I could shift over to an SICS and then I can finish off the case. So once I know the rhexis is done and I'm comfortably moving ahead with the case, that's when I go towards the phaco. And I usually have an extra side port in the nasal side. So I will hydrate it and I'll call it a day.
Just a little concern about the endothelial loss when you were emulsifying the first eye, and it was a slightly more denser endonucleus as well. So
yeah, so I was actually beating and pressing the nucleus on the IOL. So I saw the post of the patient was fine. So it might, yeah, it did look anterior, but actually I was pressing the IOL was acting like a scaffold. So I did the case with the lens in the bag.
It was under block or sedation, Dr. Pranesh?
It was block. Sedation and block local. I have asked the patient to go for GA, but it was not affordable. So I had done the case with the things that I had in my armamentarium.
I don't know. I would think of doing a scaffold if only if either the PC is gone and one fragment is there, or it's a lax bag where the posterior capsule can come trampolining, or or it's in the last fragment which you're operating, the pupil is going down and you don't want to inadvertently hit the PC. Maybe those are the situations I would, or there's a lot of positive pressure, I want the PC back. Those are the situations where I would think of an IOL scaffold. And intumescent cataract, The challenge is the rexus. And the rexus is done, why make it, rexus is like an elastic band.
Very true, ma'am. But actually, the patient was squeezing a lot. There were in very milky cataracts. I usually, with lot of cortical thing, I usually do a scaffold because there the IO will be actually the nucleus will be freely floating, and you will not have enough traction to do a crack. So the scaffold, it makes things more safer. So that is a thing which I even for IO exchange, I do a scaffold first, and then I do the IO exchange so that while cutting the thing, I don't touch the PC inadvertently. So.
Dr. Pranesh, even I wanted to just add on to that is probably there was no need to do a scaffold in these cases. I agree with ma'am. If there is like you're worried about the PC in the last fragment or very specific cases, probably we would do a scaffold. Here, especially we are concerned about the corneal endothelium. I'm sure you saw it and the patient was fine and the patient was lucky. But also as the cataract gets denser, you want to not be close to the endothelium if it's possible. And like you said, it's just something that you routinely do. So I think it would really help to get out from that mind block because it was a pretty straightforward case, especially the first one. It was mature. I agree, but not really that bad. I think you should probably start looking at not doing a scaffold routinely for your mature cataracts. You will be able to manage it. I'm sure you're quite skilled. I don't think it should be very tough for you to start doing that henceforth.
Okay, ma'am, sure.
Thank you very much. We want to next speech by Dr. Nupur Goyal, who's a consultant anterior segment and oculoplasty at Eye Care Eye Hospital and PG Institute, and again a very dynamic, very involved YOSI member. So on to you, Nupur.
I'm currently traveling. Yeah, over to you, Dr. So, hello everyone, I'm Dr. Nupur Goyal, consultant anterior segment oculoplasty at Eye Care Hospital and PG Institute, Noida. Today we're going to be discussing few lessons beyond textbooks and practical pearls to make your cataract surgeries more successful. So this is going to be in the form of mnemonic pearl. So what does pearl stands for? P for positioning and adjustment, E for ergonomics, A is ask for another, R for right way of holding, and L for learning by practice. Let's look at it one by one. So first is P for positioning and adjustment. So before you start your surgery, it's very important that the positioning adjustment is correct. The stage starts right from the patient's head. So the chin and the forehead should be aligned well. As you can see in this video, it should neither be too down nor the chin be should up. It should just align with the forehead. Next is adjusting the IPD or the interpupillary distance for getting a good focus. Also adjusting the fine focus of the microscope is important. So check the maximum at the lowest excursion and adjust the microscope right in the beginning, right at the center, so that you have adequate space during the surgery. Also, the position of the foot is important. It should be in a comfortable position, and adjusting the microscope light so that it falls right in the center. So you're well focused. So with this, we are good to go. But wait. It is very important to also focus on the other aspect, ergonomics, which is very important in the long run for a surgeon. So this is basically getting a comfortable position, which can be done by adjusting either the table height, adjusting the position of the microscope, or keep adjusting your chair height, making sure that your back is neither too hunched or neither the position is so down that you have to actually hunch over or stretch over to look into the microscope, because this goes a long way in your back also and a comfortable surgery. Also focusing the microscope is very important. So keep adjusting your fine focus till you're well focused and do not start your surgery. So you increase the magnification, you adjust the focus till your conjunctival blood vessels are well in focus, and now we are good to go. So ask for another. So what does this mean? So this specifically is important for sharp instruments like your side ports or keratomes. So check that they're not bent. So as you can see in this video that the side port is bent from ahead and it's a blunt instrument. So using this instrument can cause complications like DMD and it should not be used. So check your sharp instruments. So as you can see that the instrument has been changed, do not hesitate to ask for another instrument. The next point is R, which is right way of holding. So what does this mean? So try to understand the instrument, take support of the head end or give support to your hand, hold the instruments with the hub and understand the angulation. Also every instrument has its own specification. For example, superior rectus, holding the limbs right at the limbus so that you have adequate hold of the instrument. Your angulated instruments should be first bent sideways and then once you enter the anterior chamber, then you can bend it straight. So this is how in fact inserting your phaco probe also you should understand the correct. So last but not the least is learning by practice, wet lab, reading, focusing on each and every step. So the good successful cataract surgery following each and every step of Pearl is important. Positioning and adjusting of the microscope, the patient head, the ergonomics, making sure that you're in a comfortable position before you start operating, asking for another instrument in case of a blunt or a bent blade, right way of holding the instruments, understanding each and every instrument, and continuous learning by practice will lead to a good cataract surgery. So the final take-home message is that following each and every step of Pearl right before delving into surgery is important. This ultimately leads to a happy surgeon, and always be grateful to the OT team who assists you in the surgery. Thank you.
Thank you, Dr. Nupur. That was a very interesting way of getting across a very important information we all know. Sometimes I wonder whether it is those prolonged surgical volumes which actually cause the other issues besides just the ergonomics. And one other important thing which you could have told was the foot switch positioning. Even that is a big problem. If the foot is not positioned, the foot switch is not close to you, it's improperly positioned, that could also add to the problem. But I want Dr. Anu Malik's thought and Dr. Ramurthy's thoughts on this particular video.
Yeah, ma'am,
Yeah.
it was a very reflective video actually, Dr. Nupur. This ergonomics is a patient safety issue rather than just a surgeon comfort. I feel that ergonomics should be audited just like the surgical outcomes, because poor ergonomics can lead to tremor amplification, reduced concentration, and all these affect the surgical safety and outcomes as well. So skill may temporarily compensate, but long-term performance, safety, and surgeon longevity are compromised if we have poor ergonomics. So it was a very reflective video actually.
Dr. Ramurthy?
Yeah, I tend to agree. I know very nicely put together video, simple points, but which are very important, whatever level of surgeon you are. And maybe many of these things we do reflexly, but it's nice that these things have been pointed out. And you said about the placing the foot switches in the right place. I think adjusting the table height also before you start the surgery extremely important, so that you are not different surgeons of different height, and your reach to the foot switches is easy. And I always make it a point at the beginning of the surgery that the central button is pressed, so that whether it's magnification, focus, everything is at the center, that there's enough play on all aspects when I'm doing the surgery. Otherwise, I mean, we can go on and on about various points, but I think everything that was mentioned was very relevant to a young surgeon.
Thank you very much, Dr. Nupur. As usual, you are a very
Yes.
person. So, Dr.
Ma'am,
Sonia?
can I add a point? Yeah, can I add a point? Yeah.
Yes, Nupur?
Ma'am, yes, ma'am, can I add a few things? Yeah.
Go ahead.
Hello. Yes. So, ma'am, I just wanted to say that yes, as Dr. Anu said, that ergonomics goes a long way, not just in the comfort. So that's why I have been trained that even if it's my 20th or the 22nd case of the day or the first case of the day, I somehow cannot hold my side port till I'm very comfortable with my position. of the microscope. So that I think helps, and I think it's very important because I'm seeing a lot of young surgeons, especially with a lot of cervical issues. So this is something I think that one must inculcate, especially the ergonomics part. So this is what I wanted to especially present in the video. Thank you,
Yeah.
ma'am. Yeah.
Dr. Sonal, can you take on the next moderating bit?
Yeah, I think Dr. Lippy is going to introduce Dr. Vibha, ma'am.
So our next speaker is Dr. Vibha Singh. She is an assistant professor at Santosh Medical College, Ghaziabad, and she is going to present a video on biometry in difficult situations. Over to you, ma'am.
I just share I just share it.
Yes, ma'am.
Is it visible?
Yes,
Is it visible to all of you? It is visible?
Yes, ma'am, it is visible.
We are just going to discuss according to biometry in a different scenario. As an aphakic eye, we just use a immersion technique or modern biometer is a method of choice while we are going to put ACIL or iris claw or any SFIL, but just we keep mind for the A constant in a keratoconus eye using a K reading. In such eye will yield a overestimated reading due to the calculation error. So we use a Hoffer-Q or Higgins formula. In our eye with the silicon oil filled, we know the refractive index of oil is much less than that of vitreous. So we just increase the gain while doing the biometry using a factor 0.77 to give a rough estimate of power in a high myopic eye. There is, if we use a applanation, so then there is a paraxial measurement, or in the ultrasonic measurement, it likely to give a reflective surprises. We use a IL Master 700 with directly visualizing the fovea to the OCT image during the measurement. So the surgeon should be aimed to minus 0.50 or minus 1.0 diopter postoperative reflection, or minus IL power has to be chosen carefully by reducing the amount of minus power. In a pediatric patient, myopia increased rapidly in a pediatric age group. Goal should be correction of 60 to 70% is recommended depending upon the child age. Just keep all this in mind. We can have a better visual outcome. Under correction of 60 to 75% is recommended depending upon the child age. Another nightmare is when we are having a post-refractive patient. There may be error during the radius measurement, keratometry index error, or formula allotment error. So there are online methods are present in which Sharma's method, Higgins method, contact lens method, and Belloni method, and clinical history method we can also use to avoid the errors. We just have a single instrument for the all measurement, and the IL calculation should be according to the precise formula. While doing a piggyback IL in a primary piggyback IL, we just can use the Higgins or Hoffer-Q formula. Ideally, one acrylic and one silicone oil to avoid the interlenticular opacification. Usually, single piece in a bag and 3 piece in a sulcus. Divide the power between the IL and reduce 1 diopter for sulcus and the IL. For secondary piggyback IL, patient with the refractive error following a primary IL implantation. Calculation based on a refractive error. I just summarize in a table according to the axial length. If axial length is less than 20 mm, Holiday 2 or Hoffer-Q formula is used. If 22 22 mm Hoffer-Q. If there is a 20 to 24.5 SRKT and Holiday 24.5 to 26 mm Holiday 1, more than 26 mm SRKT or Holiday 1. Myopic refractive surgery, Higgins L. In an anophthalmic patient, Hoffer-Q or Higgins. Post-refractive surgery, topography with the TrueNet K, and flattest K with the formula according to the axial length. As we are having a very good surgery, if we keep eye on a pre-operative biometry also, then we are having a good surgical and good vision and satisfied and happy patients. Thank you. Thank you, ma'am, for giving this opportunity.
Thank you, ma'am. I think that was a very vast topic in 4 minutes. I would like to request Dr. Shreyas sir for his comments and his take on biometry in post-LASIK eyes. Ma'am, can you unshare your slides?
I'll just stop it.
Okay, you stop sharing your screen. Yeah.
It's done.
Yeah. Sorry, Dr. Lipi. You were saying biometry in which
Post-LASIK.
situation?
Post-LASIK, sir.
Okay. No, I think it used to be a vast topic earlier. I think so many formulae prior history, without prior history, using different variety of instruments. I think today we have gone on to the concept of less is more, in the sense narrowing it down to a couple of formulae. So for me, as of now, the go-to formula remains the Barrett True K. If you're using the IOLMaster 700, you use the Barrett True K TK, and that is really the go-to formula. No longer are we using the ASCRS average or ASCRS calculator as much. Haigis TK is also working very well, just going to show that looking at total keratometry, especially in these post-LASIK eyes, has a lot of value. In the normal eyes, maybe the difference between using a TK versus any of your online calculators is less, but in a post-LASIK eye where the ratios are completely altered, it makes a lot more sense to use a TK, and either a Barrett True K TK or a Haigis TK works well in these eyes.
Thank you, sir. Sir, what is your modality of keratometry in such cases? Which K values do you use in such cases?
So, optical biometer obviously helps, but essentially using your IOLMaster 700 or Anterion or any of the good biometry devices which are available today, capturing the K value itself is not really a challenge as far as LASIK is concerned, especially if it's a well-centered ablation, optic zone is not very small. So in those cases, capturing the K value is not an issue. It's really the altered ratios between the anterior and posterior cornea, and therefore using specific formulae, which is really a challenge. Can also look at the pentacam and look at the EKR report, see if you have a proper spike. Again, if it's very well evenly distributed between different formulae, then stay away from different outgoing radius. Stay away from EKR and rather use a fixed zone biometry at the 3 millimeter, like most of the biometry devices do. Because most of our regression formulae are used for that value. They don't use the SIMK values from the topographer. They are more based on the biometric values, which take a fewer points perhaps than what the topography does, but still more suited for our formula.
Thank you, sir. I would like to ask Dr. Soumya ma'am if she would like to add anything.
Yes, to start with, I wanted to tell Dr. That it was a bit too much to cover in 4 minutes, I think, especially since it's a cataract teaching video, so you want somebody to take away something from it. So probably next time you can pick on one thing. Maybe you can share a case and how you went about it. That would be a better way to present in this scenario where you have very limited time to cover. So I think even though you gave a lot of information, there was very little we took away from it. And like Dr. Shreyas mentioned, right now we have some fantastic formulae. There is Barrett's, which works for most cases. So that's a go-to formula for me for many cases. And post-refractive, like you said, it's important. You can do Barrett's True K, and you can still use the ACRS and then see how they do different formulae are doing. If they are close to each other, then great. Otherwise, it's always best to slightly, correct on the myopic side. So the patient is not you don't end up with a hyperopic surprise. Otherwise, I think, Barrett's, Kane, they're all very good formulae nowadays. And always, I would want to compare at least two if I was really concerned about the outcome, like in post-refractive.
Thank you so much, ma'am. So we can move on to our next speaker, Dr. John Davis Sakara, sir. He's a consultant at Western and Chaitanya Eye Hospital, Kochi, and he's going to present a video on how to practice eye surgery at home. Over to you, sir.
Thank you so much. Am I audible and is my screen visible?
Yes, sir.
Okay, I'll go ahead and present the video.
Master Chef Eye Surgeons have no financial interest in this presentation. Women doctors may find it especially hard to juggle their career and family life. They face intense competition at work for few successes. They often have to work extra hard to get ahead in this world. Idea, why not convert the kitchen into a wet lab? Let's take the ingredients. Do we need the fork and spoon? No. We need surgical instruments. Welcome to Anju's kitchen. And use that as the clear of the eyeball. Put it under the face made of dough. Then cut grapes to put as corneas. Watch out for the baby taking the food while you are making this. You can practice local anesthesia with syringe and needle. You can simulate the feel of a microscope by putting a smartphone between two boxes with the video mode and flash on. This gives magnification, illumination and allows you to record your surgeries. A tomato with needle and thread can be used to practice superior rectus bridal sutures. SICS tunnel can be practiced on the boiled egg using a crescent blade, even a side port, and also a keratometry. If you have a magnifying loupe, you can use that instead of the smartphone microscope. Practice capsulorhexis on the skin of a tomato which has been kept in the microwave for 5 to 10 seconds. You can also use that smartphone microscope. Similarly, you can also do a can opener capsulotomy. Nucleus delivery can be practiced with metal wire to take out a seed or garlic, for example. It would definitely be better to practice irrigation aspiration with a Simcoe cannula. Bits of tissue paper can be aspirated from any bowl. For phacoemulsification, a piece of potato can be cut out. This can be cut in the shape of a cataract nucleus and using a pencil and needle can be chopped. A cut grapes fixed on a toy can be used to practice suturing. Tomato can also be used for suturing practice. Cut out a circle of tomato skin and make a hole in the center to use as an iris. Thread the suture material through the sharp end of a needle so that it comes out of the hub. Let us do sewing machine technique of iridodialysis repair. Pass the needle with thread through the tomato and tissue paper, hold the thread, come out and pass it again through the tomato and tissue paper, and this time hold that loop of suture material while coming out. Once again, go to the next point where you want to have the suture, pass the needle through the tomato and the tissue paper, and once again hold the loop of suture while coming out so that you get the next loop. Once you have had adequate loops, you can take the thread and pass it through all the previous loops and then tie it. Now let us practice single pass 4-throw pupilloplasty. The straight needle is passed through two sides of the torn iris, and then a Sinskey hook is used to pull out a loop of suture from the distal side. Then the needle is passed 4 times through this loop of suture material. Those are the 4 passes. And then both ends of the suture are pulled apart and the knot slides inside as a sliding seepsa knot. The 2 ends of the suture can be cut with a micro scissors inside the eye. Thank you all for watching. Hope this guides you to set up a wet lab in your kitchen and practice eye surgeries at home during this pandemic.
Thank you, sir. I think it is always a joy to watch Dr. John sir's videos. I would like to request Dr. Rakshit sir and Dr. Sandeep Chaudhary sir for their comments.
Interesting video, Dr. John. Like it is really helpful, I believe, for the first or second year residents to develop a muscle memory as far as suturing and rexis is concerned. Although still, like they would need further practice for developing the stereopsis, which is also vital while doing intraocular surgeries. But yeah, excellent tool for developing the muscle memory, at least like in the beginning, first few years. So because those hectic years, might not get much time, much microscope time and wet lab.
Yes, this happened during the COVID lockdown. My
Yeah,
wife was so
especially.
frustrated that she couldn't even use the wet lab in the hospital.
Yeah.
So she ended up saying, women are not for the kitchen. And this is what we did.
Dr. Rakshit, sir.
I think that's a laid back video, change from the other stuff that's there. It's nice. It's nice to see something on similar lines we saw earlier with practicing with what you have. And I guess yes, to a fair degree you can do something, but doesn't really beat going into the theater and then operating, or going into the actual wet lab and operating. But nice video, sir.
What I found most useful was the single pass fourth throw pupilloplasty. So I had never done that earlier. So practicing this in the kitchen gave me an idea of what exactly to expect. So rare things like that, when you are, when you are in the position where you have to do it, you should have some experience like this. Even the sewing machine technique of iridodialysis repair. Never done it before, practiced this, and then I had a case where the iridodialysis happened and I could do it because I had practiced it.
Thank you, sir. So I request Dr. Tamil ma'am to introduce our next speaker.
The next speaker is Dr. Aditi Rao, Senior Resident Cataract and Glaucoma from St. John's Hospital, Bangalore. And the discussant would be Dr. Ayman and Dr. Anujit.
Good evening, everyone. Just let me share my screen.
Aditi, do you need help?
Just a minute, please.
Should we go on to the next video until she?
Yes, please. Yes, please do that.
So the next is, I think, Vasmiya, right? Yeah. So we have Dr. Vasmiya, who's doing her DNB ophthalmology from Kerala. She has a very interesting video to show. So I have my discussants, Dr. Shreyas and Dr. Soumya Ganesh, and let's watch this very interesting video. On to you, Vas.
Thank you, ma'am.
The transition to direct job is one of
I think the audio is not there, Dr. Vasmiya. Can you share with audio?
It is not audible, sir.
Why don't
Not
you?
audible. In the sharing option, there'll be an option to tick share system audio. I think you should unshare and then reshare. Once you select what you're about to share, you have to click the checkbox which says share system audio.
is one of the steepest learning curves in FICO. As a fellow, I quickly learned that the theory is easy, but the mechanics are unforgiving. Today, I am walking you through my real-world learning curve, mistakes, complication, and finally consistency. We start with my early attempts. Here, you can see the classic rocky mistake, the superficial impalement. I was hesitant to go deep. Because my FICO tip wasn't buried deeply into the core, I couldn't generate the necessary vacuum holding force. Every time I brought the chopper in, the nucleus would just displace or the tip would slip. There was no counterforce, just frustration. The lesson here, vacuum needs depth. In the second scenario, I made a critical error in the judgment. Instead of staying in the safety of the central core, my FICO tip drifted out to the periphery. Trying to chop here is a recipe of disaster. The nucleus is thinner in the periphery and the back is much closer. By applying chopping force this far out, without the safety buffer of the central nucleus, I put direct stress on the posterior capsule. This loss of central positioning led directly to a posterior capsular rupture. This is where the mechanics finally clicked. Notice the correction. I stay completely central. 1. High vacuum. 2. I bury the tip deep into the thickest part of the nuclear core. 3. The chopper enters vertically. By bringing the chopper towards the tip and separating laterally, the mechanical forces work for me. The nucleus splits completely with minimal stress on the zonutes. This was my aha moment. Finally putting it to the test on a mature cataract. Without the red reflex, the depth perception is tricky. But because I now trusted the mechanics, burying deep centrally and chopping vertically, I could execute a direct chop confidently. Mastering chop is a journey of hand-eye coordination and knowing your limits. I am not yet a perfect surgeon. I know I have so much more to learn, but every mistake has taught me something valuable. I want to express my deepest gratitude to my mentor, Dr. Matthew Kurian. Thank you, sir, for sitting by my side through the slipping fragments and the complications, and for patiently guiding my hands until I found the right techniques.
Very interesting video. A lot of learning is there in that presentation of yours. Shreyas, are you there? Yes.
Sorry, yes, yes.
So what is that single change which actually converts a failed chop to a perfect chop, Shreyas?
It's, I think the hold, which is probably the most important. I think whichever chopping technique you're using, a vertical or a horizontal chop, harder cataract, doing a multi-level chop, everything comes down to having a good hold. So ensuring that you're nicely, deeply buried into the core of the nucleus, into the hardest part of the nucleus. And it may vary. In a softer cataract, a nucleus is a precious commodity. So you don't get too many bites at the cherry. So ensuring initially itself you're holding, not eating too much of the nucleus, more of vacuum before you complete the chop. In a harder cataract, doing a small trench so that you go deep enough so that the distance between your chopping and the point of where your phaco probe tip is as short as possible, so that the chop initiates quickly and you can crack up to the posterior plate. The second most important would be to ensure that the beyond the hold is to ensuring that the chop is completed right up to the posterior plate, especially in a harder cataract, because if you don't complete it and you have multiple areas of attachments, you generally get that flower leaf flap pattern, which makes it a little more difficult to remove the pieces and emulsify them. So I think doing a multi-level chop, going deeper and deeper and ensuring that you have separated right up to the posterior plate. And these are probably the two most important things in ensuring the chop is complete.
When would you abandon the chop or switch to another technique for the beginners?
abandon chopping.
Yeah.
I think unless you've run out of nucleus, I think you should continue to chop. In a very soft cataract where you're probably not been able to complete your chop and you're a little hesitant to hold the periphery and flip it over. That might be an area where you might be concerned, especially in the beginning stages. So I think it'd be good for beginner surgeons in those situations to go and put some viscoelastic, like either a hydrodissection or a viscodissection, flip out the epinucleus along with whatever soft nucleus is left behind, and then go ahead and flip it and phaco the rest of the nucleus.
Soumya, just one other simple tip. How much phaco tip should be ideally exposed during a chop? And would you keep the nuclear density and age of the patient in your early days to influence the kind of chopping technique?
Yeah, so before I go on to that, I just like to mention that especially for beginners, I think sometimes they try chopping in sculpt mode. So that's when they end up eating away a lot of nucleus. So I think that's one thing to remember when you're a beginner and you're trying to chop, that always make sure you're in the right mode. Because if you just eat away the nucleus, sometimes they don't even realize what they're doing. So if it's not holding, do check that you're in the right parameter. That is one thing. I think embedding enough to hold. I think, yeah, again, it depends on on the hardness of the cataract. For example, if you just go by the amount that you're embedding, if it's a soft cataract, it may be too much. And for a hard cataract, you need a little more than just that. Age, yes and no. I think mostly because as you're older, you tend to have harder cataracts, but I don't think it really makes too much of a difference for me. But yes, hardness of the cataract, it would influence. Another thing for beginners would be to try and do a stop and chop technique. When you've done a trench like Dr. Shreyas mentioned, you have a good idea of how deep you are. So when you can really see where in that depth you're embedding, you feel more confident, and more often than not, you are quite successful in that chop. So I think that's a very important thing to do as a beginner, to be able to judge the depth. So when you can see it, it just becomes so much more clear.
Yeah.
I think one small addition to the points which Soumya already highlighted, I think is in the very beginning itself to start using a chopper rather than trying to. Very often I've seen young surgeons start off with a Sinsky or then go hesitantly with a slightly longer chopper and then go on to a sharper chopper. It's most difficult to do good chops with a Sinsky. Your technique has to be perfect. Whereas as a beginner, when you're still learning the techniques, if you use a slightly sharper chopper, you would definitely find chopping easier and your technique would also evolve faster. The chance of hitting a posterior capsule with the sharp tip of a chopper is so extremely rare, and that's not something we should be worried about. Even if you're using a very sharp chopper, 1.75 millimeters the length of the chopper, and the nucleus is at least 3.5 to 4 millimeters. So, I mean, the lens thickness is at least 3.5 to 4 millimeter and maybe more in harder cataracts. So there's no risk of hitting the PC. I think using a chopper in all of these situations will make it much easier.
Very valid points. We can go on to the next speaker, or rather Aditi has a video ready, I think. So she can be taken on. Dr. Tamil?
Yes, ma'am. Dr. Aditi, can you go to...
Yes, ma'am. Good evening, everybody. I'll just be sharing my video.
Dr. Aditi, you have to unmute yourself.
Yeah, good evening, everybody. Sorry for the delay.
My deep bowl of despair. So while I was chilling around in the OPD, this old guy with super exfoliative glaucoma and narrow angles came to me. He had a soft cataract and a whole lot of things that were wrong with him: hypertension, chronic kidney disease, and he was on alpha blockers and antiplatelet medications. Endothelial count was 1200, and I really didn't know what to do, and he wasn't going anywhere else. I managed to do a decent Rexis and thought that maybe he would have a floppy iris, so I made longer corneal incisions like Dr. Devgan does. Then I went ahead with the hydro and tried hard to get it to spin like Rosatelli. So I got it to move, but not exactly spin, more like a slow merry-go-round maybe. And there it is, it's going around very, very slowly. Nope, that didn't really spin. It was more like a merry-go-round, slowly. Sadly for me, I thought it was good enough. I filled the eye with viscoelastic like Arshinov and hoped for the best. For the phaco, I couldn't decide between divide and conquer or phaco chop, so I did something that was the best of both, the stop and chop. By Cock. When I thought the trench was deep enough, I could see the reflection, and then I tried to crack it, and it just wouldn't crack. There was some cheese wiring. I turned it around. And then I thought I should go ahead with the phaco. That was not a good decision. I thought I could just go ahead and grab it and get it out. And then I tried grabbing and impaling it and turning it around. And after all the jiggling, wiggling, and the dancing around, and there it is. Oh God, I'm so embarrassed by this. Yep. Nope. That was not supposed to happen. That was also not supposed to happen. I went inside with my probe. I tried to fish it out. That didn't work. Then I readjusted the phaco settings just like I had to drive my dad's car. Power to 0, increased the vacuum to 400, and hello dear, I finally picked it up and ate it, and it didn't break the capsule. So if you've been chilling around and things don't go as planned, and you should train, readjust, and do it somehow, my favorite technique by Dr. Mohanta. The rest of the case was okay only. There was a little bit of visco and the cortex, which I cleared out. And then I put in the IOL, which was an Alcon IQ lens, in the bag, and I could see the shiny white reflex in the middle of the cornea. The post-op was okay. The patient had a vision of 6/6, and thank God nobody died.
Thank you, Dr. Aditi. And that was a nice illustration of how to manage a failed chop and if we end up in a bowl. And the discussion would be Dr. Ayman and Dr. Anujit. And these are the cataracts where it is difficult to crack and also difficult to chop. And what would be your preferred technique in these cases, Dr. Ayman?
Yes, ma'am. So in these cases, I think Shreyas sir had already once mentioned that you don't really get more. Yeah, so you don't get maybe just one chance to complete your chop before the cheese wiring happens and the bowl formation happens. So what you should do here, I think, for maybe a beginner surgeons, is hydrodelineation really helps to differentiate the nugget of endonucleus which you need to tackle first. So do a hydrodelineation. And a mechanical fracture technique in these cases is very efficient. So you can just use a phaco probe and dialer or whatever left-hand instrument you have to just go around the delineated endonucleus and just bring them two together. So that will give you two separate halves. And once you have that, you can just aspirate either of them away, or in case it's slightly more harder, you can make into 4 pieces. So that way you can efficiently get the nucleus out. If the bowl formation is happening and it's not coming out, instead of trying to repeatedly go in with a phaco probe, a safer technique would be to just hydroprolapse the nucleus out. So that way you can just get it out much safer. And once it comes out again, when you go in the phaco probe, it tends to go back down. So you can just sometimes even use the second instrument on the left side to just lift up the nucleus, slightly tilt it up and just aspirate it down. So I think mechanical fracture and hydroprolapse really helps in these soft nucleus.
I think her first concern was IFIS happening. So to prevent that, it's always better to use very low fluidics, because the primary reason why IFIS can precipitate and become worse is because of turbulence within the chamber. So that's number one. And number two is that when you're thinking that your nucleus will become a bowl, it's primarily happening because you're moving into foot switch 3 or phaco power. So ideally, we usually start with 0 longitudinal and maybe 20 or 30% torsional power when we are beginning. So it's better to actually convert the phaco power to 20% or 10%. And like Dr. Eamon said, that if you're thinking of a mechanical chop and if you're unsure you would go into foot switch 3, just take the machine and put it at 5% torsional power. So that's where you can start preventing. Usually the bowl starts happening from one side and then it extends into the other side in most cases. So the best thing to do would be to just modulate the machine, decrease the phaco power. You want to hold on to the nucleus with a bit of vacuum. I think another thing that residents miss out is that vacuum will only rise when there is occlusion in a peristaltic system. Just because the vacuum on the machine is 400, 450, 500, doesn't mean that the machine is generating that much vacuum unless there is full occlusion. So having said all that, the first step would be to maintain low fluidics so that you're not putting pressure, and start with initially a groove and then go for trying to separate as you would go for a stop and chop. And at the moment you see that it is cheese wiring, just decrease the phaco power and go for a very slow cleavage between the two heminuclei. I think that would be the best. And other than that, I think Dr. Raymond explained it. You can always prolapse the nucleus by putting viscoelastic into one pole and taking it out.
And also we noticed too much of an intrastromal hydration happening. Your tips to prevent.
Sorry, ma'am, I just didn't catch you.
No, intrastromal hydration, along the phaco.
Yes.
Communication.
Yeah, so I think the machine used was a Oatly machine, and sometimes so the best way to prevent it is to just make sure. Actually, I think because it was a long tunnel in this case, there was a lot of intrastromal hydration. But going a little bit more interior and going for relatively normal size intracorneal tunnel would also do in such a case. So in cases of IFIS, which I do, I make my corneal incision quite anterior, but I keep the length of the tunnel the same. So in that case, the irrigation port that is coming out of the phaco tip is well out of the corneal plane.
Can we move on to the last speaker?
Yeah, now I welcome our non-competitive entry from our neighboring state of Bangladesh. Dr. Tahmina will be sharing the management of white intumescent cataract. Over to you, Dr. Tahmina. And Ramamurthy, sir, would be taking the first question after her presentation. Followed by Dr. Anu.
Thank you for giving me the opportunity. Good evening. I'm Dr. Tahmina Rashid Rashna, going to show a hypermature case, fact of a hypermature case. Okay. Side port is made. Then trypan blue is given and kept it for 10 seconds and middle. Then I fill the anterior chamber with OVD, and I will go for double rexis as the lenticular pressure is very high. So I nick at the center of the capsule, then doing my double first rexis, and the movement should be tangential. And as the cortical matter is liquefied, so I didn't get support underneath the capsule, so I use rexis forceps. Then for the second rexis, I cut the capsular margin with microforceps and tangentially cut this with rexis forceps, and the rexis should be adequate in size. And also during capsular rexis, I must remember that the anterior capsule anterior chamber should not be collapsed, and the flap must be flattened. So we are getting the adequate size rexis, and it is well centered. Then I go for second side port, and I didn't do hydrodissection. I only rotate it because the cortical matter is liquefied. So in this type of case, we didn't do hydrodissection. We need not to do. Then I go for sculpting. I use torsional energy. I go for modified chop technique. So I furrow the central part. Then I go for chop in longitudinal energy. I preferred longitudinal energy during chop technique for better holdability and good vacuum. And I go for 6 pieces quadrant, and it should the chopping should be in good control way, because I don't want to stress journals or stress the rexis back. So now I go to quadrant removal, and here I use only torsional energy, so that the lens shattering will be minimal with good foot control, and the energy must be in linear mode. So during last pieces, I changed the Sinski and took spatula. The bag is empty, so there must be chance of the posterior capsule maybe come out and upwards, and there may be PCR, risk of PCR. So cortical matters are very little. I put the intraocular lens, then do cortical wash, and then do visco wash. Then wounds are sealed with stromal hydration. So in this type of cases, the challenge is mainly the perfect capsular axis, because the lenticular pressure is very high in this type of case. So I go for the double axis method, and during nuclear management, I go for modified chop technique, so that the nuclear there is less compression over the zonule, or less pressure in capsular bag. So this is my presentation. Thank you.
Thank you very much, Dr. Tamina, for your excellent video and sharing these various pearls with us. I would request Dr. Anu Malik and Ramamurthy sir to please share their pearls regarding management of similar cases.
I think nice video and several teaching pearls in that. Would you like to go first, Dr. Anu? Go ahead.
Yes, sir.
Go ahead.
Like, any intumescent cataract surgery is basically a planned pressure control procedure. Like, I feel that it is not a routine phaco. Like, success depends definitely on the anticipation and flexibility in the surgical strategy. We already know that there'll be a raised IOP, there'll be shallow AC, there can be convex anterior capsule. We know the lens thickness is increased. So we can have preoperative measures like IV mannitol, adequate mid-RASes. We have to use cohesive OVDs, and like she said in the video, it was an excellent video. Like a modified two-stage capsulorhexis was preferred here. A gentle hydrodissection as well as viscodissection can be used, and any forceful maneuvers should be avoided. Low flow, low vacuum, and sometimes even phaco aspiration will be rather preferred over the aggressive chopping. And like control can opener extension, sometimes it happens like we have an Argentina flag sign also, which needs to be managed intraoperatively with the high viscosity OVD, modified nucleus delivery strategies can also be planned. And it basically depends upon the anticipation as well as the flexibility in the strategy of performing the surgery.
Actually, if Dr. Amuti will not mind, I wanted Dr. Tamil to comment on this intumescent cataract. She has a very good thought process about it. Tamil, can you tell?
Yes, ma'am. Dr. Takmina very nicely shown video. And the capsulorhexis is the most difficult step. Once it is done, I think the rest of the surgery is going to be a routine case. And initially, the choice of viscoelastic, I think it is going to be a cohesive viscoelastic where we want to flatten the anterior lens capsule. And second, while initiating the tear, instead of raising a flap as a linear tear, which has a chance of extension on both sides due to bidirectional force, vector forces, it is better to raise, it is a C-shaped flap so that the chance of extension is going to be less. And a two-staged capsulorhexis is preferred because we can decompress the nucleus. And one thing we have to notice that the intralenticular pressure is not only limited in the anterior lenticular compartment, but also the posterior lenticular compartment. So when we're aspirating the cortex, it is essential to gently rock the nucleus so that whatever fluid is collected in the posterior lenticular compartment also comes out. Once it is done, I think it is better to enlarge using the microrhexis scissors and forceps. And also while propagating the rhexis, it is important to paying attention to the point of tear. And if it is pointing towards the periphery, and it is better to stop, inject viscoelastic not in the center, just beyond the point of tear, and employ the Bryan's little technique, where we flatten the anterior lens capsule, hold close to the point of tear, and pull it in the opposite direction, in the direction of the area of completed rhexis, so that we can bring back the rhexis. I think paying attention to all this, rhexis could be done successfully in these cases.
Yeah. And also, there's a good understanding about doing a mid-peripheral small opening. These are different thought processes for a thing, because the central opening is the thinnest part of the capsule, which can rupture and give way. So it is, if you make a small mid-peripheral opening and then you evacuate the cortex and then you make the anterior capsule more concave and then you enlarge the rhexis, and then that would also be ways. You manage your case very well, but we just wanted some thought processes of a different scenario. And ideally, if you have access to ASOCT, you can even get to understand what are the grades of intumescence. So it is in that grade 2 when there is a lot of swollen lens fibers and fluid clefts. That is the time the case which can run away. So then that is when we need to be very, very careful of making a very small opening or a C-shaped opening or a mid-peripheral opening. Whereas in a grade 3, grade 4 kind of ASOCT, then you can do maybe even get away with a small central opening. So
thank you, ma'am.
Very nice presentation. So Sonal, would you want to say something concluding?
Ma'am, before we conclude, actually, I want Lippy to now announce the audience poll.
Yes, I request Manjula ji to please start the audience poll, and I request all the audience.
Something, I'm sorry. I intervened. Dr. Ramurthy, you have some comments?
I think I should have taken the first chance and gone ahead. Three of you have finished and nothing much is left. Anyway, I think it's a very nice video and all the good points were made. And just a couple of things, maybe I would, especially for a young surgeon, a peribulbar anesthesia, apart from acupressure and maybe glycerol to detoxify the vitreous would be a good idea. And then I did notice that, all the points about making a curved incision that on the capsular while making the capsular access is
हेलो
ideal. And one
नमस्ते
thing I
मम्मी
noticed
कैसे हो
was that
सुबह भी आपका
she was
हाँ
doing the
हाँ
exercise.
घर पे ही हूँ
Mute yourselves, others. Yeah.
She was doing the rexis through the using a cystitome through the main incision. I think if you go through the side port incision, that would give a better control. And second thing is, as far as the aspirating of the lens matter is concerned, I didn't see that much happening. Maybe it was not a very intumescent cataract; it was more flocculent, but otherwise enough aspiration after the initial opening was made, and then rocking the lens so that, as Tamil said, some of the lens material from behind the nucleus also comes forward, and you really get a flat anterior capsule. Basically, all our endeavors are towards making sure that the intracameral pressure is more than the intralenticular pressure. And when she was injecting the viscoelastic, sometimes I felt that it was going towards the opening that was always created. It's always a good idea to go to the intact capsule in the periphery and then inject there so that the capsule gets flattened up. One thing that I liked and I use commonly was I don't know how many of you are doing it, is that for chopping, I also use purely longitudinal phaco, and that's because I think that gives a better hold on the phaco fragments and allows you to chop better apart from all the other factors that were also earlier mentioned. When you use torsional phaco, there's a little sideways movement and maybe the hole gets a little loosened up, and I use purely torsional phaco for during quadrant removal. I think that's a really economy of energy that's used and more controlled removal that happens. Otherwise, I think all other points are covered.
Thank you.
Thank you, sir. Thank you.
Thank you, sir. I would now like to request Manjula ji to start the audience poll. Manjula ji.
Yes, doctor, one second.
So the audience poll has started. Please vote for the best teaching pearl.
Is this for us on Zoom or for people who are on YouTube?
It's on Zoom, ma'am.
So for all of us that are here?
Yes, ma'am. All the audience can vote. Can we close the poll?
Yes, doctor.
I would now request Sonal ma'am to please take over.
Are the results being shared here, Lippy? I'm a little
Yes,
confused.
ma'am, they are with me. I'm just writing them. Yes.
No, I mean the results of the poll. There came an option that share the result, and then that option disappeared.
You want the results to be shared to all or only to you, madam?
I think the audience poll can be shared with all. No.
Hello.
We could see the results. We already saw the results.
On the result.
Yeah, it showed share results from on my screen, and then that disappeared. I don't know. If you can please show the audience poll result on the screen again. So I think we can see that the audience poll winner is Dr. Nupur this time with 21% votes. And Dr. Shantanu is the runner-up.
Dr. John and Shantanu have equal votes.
All is not showing here.
Yeah, actually, only half the screen is visible even in my system.
Madam, you need to scroll up and down to view the results.
Yeah, it's not getting scrolled actually. That is a problem. Anyways, I hope the results can be announced by those who are able to scroll. Lippy or Chitra ma'am can please announce the results.
Comes first, and Dr. Shantanu and John Davis second. Share the runners up. And that's how it is.
And the results of the judges, I think, are being collated by Dr. Lippy Mittal.
Congratulations, Dr. Nupur, and congratulations, Dr. Davis and Dr. Shantanu. But all of you all did nicely. Gave your best, and was a teaching pearl, and the mistakes from which how we correct. So there was good effort by all of you, and congratulations to all of you young surgeons for trying to be your most innovative and give your best. Really proud of all of you. You all have way ahead to go. You'll do very well.
So after calculating the judges' marks, the runner-up judges award goes to Dr. Vasmia, and the best teaching pearl goes to Dr. Rohit Rao.
Oh, okay.
Congratulations to both of these winners. And I really believe that all of these people are winners in some way or the other because they've brought about such a variety. Ma'am, don't you agree? What a variety of videos we saw, from positioning to, to the management of even, open sky cataract surgery has been covered. So like what a wide variety that we had.
Very nice iris enclavation pearls which were shown. That was also a very nice video. And true, I mean, every video, if we dwell for a moment on it, even Pranesh's video, all the videos had a good pearl there. So yeah, all very nice. The subluxations, everything was dealt well. So kudos to all of you. Very good. A big round of clap for all of you. Do the judges have anything to tell before we close for the day? Judges or the expert panel, anything to comment?
They were all very interesting, and some of them were so out of the box. It was a pleasure to see. There can only be one winner, or you can only give 2-3 places out. So I think that's the limiting factor. And most importantly, I think what was important was to have a takeaway message at the end of the video, since it is a cataract teaching video. But otherwise, very well done. It was a pleasure to see all these videos.
I think very well done, all youngsters. I mean, they all put in their best, and it was a very wide variety covering almost the entire spectrum. A lot of teaching pearls. Congratulations to each and everyone.
Yes.
I think it's already has been mentioned. Very, very impressive ones. In fact, it's not just the ones which had surgical complexities, but even entertaining videos and mix of and obviously all very confidently spoken and very good science in almost all of them. So really enjoyed being part of the webinar. Thank you.
Thank you very much. Thanks a lot, YOSI.
Ma'am, before we close, let's take a group picture. I would request Manjula ji to please click a picture.
Sure, Doctor.
Yeah. With the YOSI sign, ma'am.
Finance, and you should be well versed with your accounts, and that is why we have webinars like this. It is just not the practice that matters. The way you do it, the way you go about your finances is also
Taken, Doctor.
we are at that.
Thank you so much to the I Foundation group for liaising with YOSI for this, and we are extremely grateful to the judges who've given so much of their time, and Dr. Lippy needs so much appreciation for coordinating everything so flawlessly.
Yeah. Lippy, really got to understand what a perfectionist you are. Very thorough and follow up, and everybody did very well. And we have to thank Velmurugan also, who this particular event was totally coordinated between Velmurugan and Lippy. So they did it so well. At least last time myself and Sonal were very much involved. So 3 cheers to all of you. Thank you very much. Thank you and good night.
Thank you, ma'am. Good night, everyone.
Thank you. Thank you, everyone.
Thank you.
Thank you. Thank you. Bye.
Thank you.
Thank you.